Bien bueno, con los tostoncitos. Ay, qué rico. En verdad fue todavía no tengo eso. A mí no me parece eso. Porque la dinámica de la no me sale. That's funny. ¿Qué pasó de antes? Yo voy a los míos.
I do. I watch some of my old skinny pops. Yeah, I still watch skinny pop. I'm talking about drawing one son. I'm all big on for 20 weeks on this.
Yes. Like, let's sit down. She had that. We have to look at it.
I'll just excuse myself.
We were supposed to start at 1:30 today, right? Yeah, they do only 1:30? Yeah, that's what I thought. Not sure what's going on with Dr. Gonzalez. Okay. Give me 2 minutes. I just want to see if Dr. Gonzalez is down in the office.
Vamos a ver cuánto la misma que tiene. So, si tú tienes 15 en 7 meses, ¿cuánto tú vas a tener?
So you guys all know Dr. Gonzalez? Have you had him before?
Hello.
No? Dr. Jeff Gonzalez, he's one of our newest faculty members in the Clinical Administrative Sciences Department. He's been with us since the summer.
Yes.
And has got a wealth of, decades of experience in pharmacy education and pharmacy practice, and we're so thrilled to have him here. And this is your first PT lecture, isn't it?
For P3s.
For P3? Oh, you did P2 lecture?
Yes.
Okay, so you're a grizzled veteran at this point, right? Awesome. Let me give you a hand with the mic here. Have you ever used this?
Yeah. Can you guys hear me?
No.
No.
But we're going to get that fixed in just a second. Oh, so the room, and I think it's wireless one. Try it now.
Check. Can you guys hear me now?
Yes.
Awesome. All right. Let's get this started. So this is an awesome lecture, acute decompensated heart failure. You've heard about chronic heart failure, of course, over the past week or so. This should tie in well as far as a transition from that.
We should rebrand this lecture. It should be called "When Things Go Horribly Wrong."
Yes.
Right?
Yes. And that's exactly how the patients present. As far as learning objectives, please familiarize yourself with these. This is what the case application and the exam questions will be based off of. So if you know these up here, you should do quite well. Would like to start off with disease management and just an overview of what we're going to be talking about today. Certainly, we want to identify factors that lead to acute worsening of heart failure. And some of these factors may be the same as what you've already heard about for chronic heart failure. We want to classify acute decompensated heart failure based on clinical presentation, determine the goals, therapeutic goals, of course, for these patients, and then recognize pharmacologic and non-pharmacologic interventions for the management of these patients. And then finally, describe overall goals for care in managing acute decompensated heart failure. As an introduction, about 7 million U.S. Adults will present with acute decompensated heart failure. This corresponds to 1 million hospitalizations yearly. 90% of these admissions to the hospital are due to fluid overload. 25% of these patients will be readmitted to the hospital within 30 days. So you can see that this is a significant issue for healthcare. Those admissions will increase costs, will increase load, and are not good for the patient, of course. 65% of these patients will be readmitted within the first year. This attributes to about 40% mortality for these patients. So when they get admitted for acute decompensated heart failure, they already have approximately a 40% mortality. Huge. And then the costs are shown there, $70 billion by 2030. So what is acute decompensated heart failure? It really is a rapid and worsening decondition of chronic heart failure patients. It's typically related to severe congestion. You've heard about the congestion over the past week and modes of therapies to alleviate congestion. So these patients come in with severe congestion, dyspnea on exertion, et cetera, and we'll get into that. But certainly, as you can imagine, they require urgent medical therapy. So I want to, you guys to focus on the right-hand side of this. So certainly they have the chronic underlying cardiac dysfunction. And then there's some type of precipitating cause. And that's very important because it's different for every patient. And as healthcare providers, we want to identify that precipitating factor or cause to help treat the underlying disorder. So they could come in with right ventricular dysfunction, but again, severe systemic congestion. So always think about that as far as a treatment. So it really is a disease progression from the chronic heart failure to fulminant decompensated heart failure. All right, pathophysiology.
Thank you, sir. Let's see if we've got the. Give me 1 second here. Just want to get this over here. All right, let's go back over here. Okay, I've been hitting the Mountain Dew pretty hard this week. It's P1 Success Week, so I've been doing about 3 hours in the morning, and so I'm trying to keep my voice going, and that's why I'm using the mic today because I still have a couple of days left. All right, so as Dr. Gonzalez was talking about, this is kind of the acute decompensated heart failure is kind of a sudden onset sort of event, and it's a progression of the chronic heart failure condition that we were talking about over the last couple of days. And I think that there's a couple of things to really point out here that are super important that are going to tie in directly to what Dr. Gonzalez is going to talk about in terms of the way patients present and some of the symptoms that they present with acute decompensated heart failure. So it is an acute sudden decline. So this is when things go wrong. You have someone who's being managed, and Dr. Gonzalez has a whole slide with a list of precipitating factors that can cause someone to go into acute decompensated heart failure. And as a result of this sudden decline in heart function, a couple of things are going to happen. We're going to get a further decrease in cardiac output. So we already know in someone with chronic heart failure, their cardiac output is impaired as compared to someone who's got a normal functioning heart. And in acute decompensated heart failure, that cardiac output actually gets worse. And one of the end results of that, there are a couple of different things that happen as a result of that, but one of them is a decrease in delivery of oxygenated blood to the body. And so, again, we are going to see poor peripheral tissue perfusion and organ perfusion with this, and that can be a real problem. So we're going to be talking about patients that are cold and wet, okay, and we'll explain what that means, but these types of patients have poor perfusion to peripheral tissues and organs because cardiac output is so poor. Okay? The other piece of this is the congestion or fluid overload that Dr. Gonzalez mentioned before. And this typically manifests itself as systemic or peripheral edema. Okay, and again, we have the typical ankle swelling, and there are other things that Dr. Gonzalez is going to talk about. As well as pulmonary congestion, so buildup of fluid in the lungs. And I want to go back really quick. I like this slide here that he was presenting because I think it shows something that's super important. and in terms of understanding why this congestion occurs. And in order to understand that, you've got to remember your cardiovascular anatomy, okay, in terms of how the heart is kind of plumbed and connected to other organs. You remember, okay, that blood comes back into the heart via the venous system through the superior and inferior vena cava, right? Right into the right atrium, right? And then the blood goes into the right ventricle, okay? And then it goes into the lungs via the pulmonary artery, right? And comes back to the heart via the pulmonary vein into the left atrium, and then the left ventricle, and then the aorta, okay? When you have a situation where you have acute decompensated heart failure, what can happen is that cardiac output falls sharply, okay? Blood starts to back up. All right. How many people here have been on the Beltway when there's an accident in traffic or there's construction and traffic's backed up? That's the way I love to think about this. Yeah, I think about the heart, the whole cardiopulmonary circulation as kind of like the Beltway. All right. And if the left ventricle isn't functioning very well, it's like that's where an accident is on the Beltway, and then things start to back up. So blood starts to back up from the left ventricle into the left atrium, back into the lungs. Right. Blood starts to back up there. And then pressure in the pulmonary capillaries starts to increase, and water starts to leach out of those capillary beds, and that's where we can get the pulmonary congestion. And again, the backup will continue into the right ventricle, right atrium, back to the venous system, and pressure builds up in the venous system and in the capillary beds, and water starts to leach out there, and that's where we can get our systemic congestion or peripheral edema that we see with that. So again, getting things moving again, reducing preload on the heart, those things are all super important in order to relieve some of these issues. Okay, as Dr. Gonzalez had pointed out, this is, again, a life-threatening condition. This is a very serious condition when patients are admitted like this. And so you're going to see that the treatment that we use for this is certainly more aggressive, I think, than with chronic therapy. And, because the goal is to get the heart functioning in an appropriate way as quickly as possible. Now, in terms of compensatory responses, this is a picture that Dr. Gonzalez found and came up with, and I really like it. And it's very, very similar to the pathophysiology slide that I've been using yesterday and the day before, where we talk about the neural hormonal components of heart failure, right? And this one is a great illustration showing here the cardioregulatory centers in the brain and the medulla, okay, that regulate things like heart rate, stroke volume, peripheral systemic vascular resistance, and those sorts of things. And again, as blood pressure falls because of the failing heart or a reduction in cardiac function, the body will respond by activating these compensatory responses to try to bring blood pressure up and get things functioning normally. And these compensatory responses involve the sympathetic nervous system. Okay, we talked about that, right? We talked about the effects of the sympathetic nervous system on vasoconstriction and afterload. Okay, we talked about the ability of the sympathetic nervous system to activate the RAS system over the last couple of days through beta-1 activation on the juxtaglomerular cells. We talked about the effects of the sympathetic nervous system on cardiac remodeling, right? Beta-1 receptor downregulation, cardiac muscle cell apoptosis, and we also talked about, again, cardiac remodeling, fibrosis, hypertrophy, and those sorts of things. One of the things that I didn't have on my other slide, but is equally important, is this is arginine vasopressin, otherwise known as antidiuretic hormone, or ADH. You probably know it by that name. And again, this works in conjunction with aldosterone to help promote water retention in the body. So again, there's a lot of complex things that are going on here neurohormonally when the body's attempting to regulate cardiac function, especially when there's something wrong with the heart. Okay. Again, same information on that other slide, but this is, I think, a nice condensed one, and you're ready to take a look at this and see this. Dr. Gonzalez, anything you want to add to that?
No, I think that's perfect.
Okay. I think this is your slide, actually. Okay. Yes, we had a question.
Yeah, so the ADH is a compensatory mechanism because of the drop in cardiac output.
Exactly.
But that doesn't help because you you would send more water, and it's like a cascade. Right?
Exactly. And so again, all of these normally, like I said, normally if there was let's say there was a fall in blood pressure because of volume depleted for some reason, okay? All these same compensatory mechanisms would kick in and actually help bring your blood pressure back up. The problem is that in this case here, the heart is not functioning appropriately. And so these compensatory mechanisms kick in, but they can actually make things worse. You're right, absolutely. So remember, in chronic heart failure, our goal is to use drugs to actually modulate or control or even depress these types of neurohormonal processes to prevent cardiac remodeling and to keep fluid levels at a normal level. Great question.
Thank you.
Thank you, sir.
It is a great question, and I think you said this, but in a different way. It is a vicious circle.
Yeah.
So once all these things happen, once the body senses that it's not getting adequate cardiac output, you have all these compensatory mechanisms going on, but it actually, when it gets to this stage, it's not helpful because you have the body's trying to vasoconstrict. That's increasing afterload, that's increasing work on the heart, and it's just a vicious circle, and you get worsening cardiac output. So this sums it up well, and if you guys know what's going on as far as the pathophysiology, this is a cool part because the treatment is so much easier to understand of what we choose and why we choose each agent. You've probably seen a similar graph as this.
Yeah, so this is a Starling graph, okay? If I can jump in here real quick to translate. What you guys have seen so far is you see on the x-axis there, it says pulmonary capillary wedge pressure. So that's a clinical measurement of preload. So again, if that doesn't mean anything to you or you're a little confused by that, just put in preload right at the bottom, okay? And then on the y-axis, all right, we have cardiac index. Again, that's a measurement of cardiac function. We talked about it in terms of cardiac output. So that's another way of looking at it. And Dr. Gonzalez is going to explain these four quadrants. And then we're going to take a look at these four quadrants with Starling curves on them and kind of show you how patients can change their position on their Starling curve with heart failure or with treatment, actually move to a better Starling curve.
Excellent. So again, this is the bottom is preload and then cardiac output. So you guys know that in a normal state, what do you want with preload? Is it going to be on the left or the right? Arrows kind of help you out, right? Red is bad. So it's going to be on the left, right? You don't want too much volume in your body. And then for cardiac output, you want it high or normal, right? You don't want it low. Low is bad. So, so normally these patients, hopefully with therapy with chronic heart failure, they're living closer to this upper left-hand quadrant. That's the ideal situation. That's kind of where we want to get them. But when they come in with acute decompensated heart failure, they're probably going to be congested, right? We said that. So they're going to have a fair amount of congestion on board, both pulmonary congestion and systemic congestion. So their preload is going to be on the far right with ways that we can measure preload or estimate preload in the ICU or the ED. And then their cardiac output may be halfway to normal or depressed. It's probably going to be a little bit depressed from normal, so it's not going to be all the way up there, but it's going to be around like 2 or maybe even quite a bit less than 2. So depending on where they come in as far as this graph, clinically we can add agents to alleviate their symptoms, and you're going to see this in several slides. So these quadrants I think are important because they put together the pathophysiology of what's going on with that patient, and then we can target that to reverse that. So if a patient comes in with pulmonary edema, we're going to give them drugs to get rid of that fluid, right? What's one of the drugs that we use to get rid of fluid? Diuretics. Awesome. So you guys know this already. If they come in with congestion, we're going to give diuretics. But what happens if they come in with a low cardiac output? What can we do there?
Sympathomatics.
We can give something to increase the cardiac output. So we're going to talk about specific therapies that can do that.
Can you give like, I don't know if it's, can you give like fluids for, because you know patients going to be fluid overloaded, but can you give like fluid resuscitation to patients that are like high, like that have like very low cardiac output?
Great question. So if they have low cardiac output and so would you give fluids, intravenous fluids in that particular case? Probably not, because these patients, majority of these patients are going to come in with fluid overload. So they're going to have systemic fluid on board that is too much and intravascular volume that is too much. So generally what we're going to do, even if they come in shock, we're going to try to diurese, gentle diurese, and then add other agents to kind of increase cardiac output to improve blood pressure, and then maybe a vasoconstrictor, depending on the patient. Correct. So like a pure vasoconstrictor, alpha-1 agonist. So again, if you guys understand these 4 quadrants, when you come to a patient case, think in your brain, okay, what quadrant does this patient fall in? And that's going to dictate your therapy. And we're going to come back to this when we talk about therapeutics.
Prof, what do you mean by dry and wet?
Great question. So dry and wet. So wet. So again, these patients are going to come in with a lot of volume on board. That's wet, right? Too much fluid is wet. We want them on the dry side. So we want to decrease fluid to go to the dry side. Cold and dry would be, because they don't have adequate cardiac output, they don't have adequate perfusion to their vital organs. So they're going to have signs and symptoms of decreased perfusion, and we call that cold. These patients, if you do a physical exam on them and touch their extremities, because of decreased cardiac output, because of decreased perfusion, they will actually feel cold because they're not getting enough blood to their vital organs and extremities. So that's why it's called cold and wet, or cold and dry. Usually, well, in this case, they're never going to present as warm and dry. They're probably going to present as cold and dry or cold and wet with acute decompensated heart failure.
If I could add one other thing too, the way I like to remember this, how many people have ever been camping before? I better see some hands. You've been camping? All right. If you haven't been camping, imagine going camping out in the woods, okay? And I'll take you sometime if you guys want to. We'll go do a group camping trip, okay? If you're out in the woods and you're camping, what do you want to be? Warm and dry. You're going to be a happy camper if you're warm and dry, right? Trust me, I know. Because I've been in all 4 of these quadrants when I'm camping. Cold and dry, not so great. It's not good to be cold, but at least you're not wet. You're miserable if you're cold and wet. If it's 38 degrees and raining, you're in big trouble. Hypothermia, right? Warm and wet is no fun either. I don't ever go camping in July because it's just too hot and miserable. You can't sleep at night, right? So when you're thinking about these 4 quadrants, right, 3 of them are not great places to be, right, if you're a camper. Warm and dry is where you want to be. You're nice and cozy in your sleeping bag. You're ready to go to sleep. You've had a good meal. It's nice and warm. It's dry. Your tent's not flooded with water. You're in good shape. So that's the way I always remember that.
Awesome.
Okay?
I love it. Love it. So how do we approach these patients when we see them in whatever setting they present in? First, you want to look at precipitating factors. So remember those factors that can trigger an event like this, a decompensation, okay? We certainly need adequate patient history, so we're going to collect patient history. What did they do in the leading days that came to this? Definitely have a physical exam. So we're going to look at signs and symptoms of volume overload or fluid overload. We're going to look at signs and symptoms of hypoperfusion. And again, based on that, we're going to put them in one of those 4 quadrants, like we said. We're going to order some laboratory tests and maybe imaging to help make the presentation clear. And then we're going to classify the patient as either warm or cold, or cold or wet, or warm and dry, or cold and wet. So common precipitating factors, and you guys probably know these. So anything that's going to affect the heart function, right? Acute coronary syndrome or myocardial infarction, certainly that can decrease cardiac output. Uncontrolled hypertension, especially if it's severe hypertension, that's going to affect the way the heart is actually functioning. Atrial fibrillation and other arrhythmias for sure. I would throw in there mitral valve disease as well, or endocarditis. Acute infections can certainly affect how well the heart is how well the heart is functioning, especially if they're severe. So maybe severe pneumonia, maybe a UTI going into sepsis, etc. Non-adherence, huge cause. Non-adherence to diet, salt, of course, or medications. And then medication-related things such as NSAIDs, which will retain fluid in our patients, and we kind of want to avoid those in these heart failure patients. Or medications with negative inotropic effects, right? Verapamil, classic drug, the calcium channel blocker, or flecainide, antiarrhythmic. Anemia makes the heart work harder. So if it works harder, just like if you're exercising, too much exercise, maybe not a good thing. And then hypothyroidism, that definitely affects the heart. So remember some of these precipitating factors, because your patient will probably have one or maybe even several of these. And what you want to do is identify them and then treat the underlying cause if you can. That's always important. So clinical presentation, as far as symptoms, what are they going to feel? What are they going to tell you when they present? So we have wet and cold, or low cardiac output over there. So as far as wet, similar ones that you've heard about in chronic heart failure: dyspnea, or orthopnea, peripheral edema, weight gain over the past days or weeks. Poor appetite and nausea. Why would these patients have poor appetite and nausea?
Not space. Yeah.
What's that?
There's not a lot of space due to all the fluid.
So you can have like systemic congestion, right? Maybe it's impacting the liver or the GI tract. So yes, congestion within the GI system. Paroxysmal nocturnal dyspnea, and then overall ascites. For low cardiac output, we mentioned some of these, but one of the first things would be altered mental status, right? If you don't have enough cardiac output or blood supply going to your brain, you're going to present with altered mental status. So that is a common one, especially in the elderly. Fatigue, overall fatigue. Again, due to decreased cardiac output, these patients will just feel, just really fatigued. GI symptoms and decreased urine output. So some of the signs that can be seen on physical exam for fluid overload, certainly pulmonary crackles or rales when you listen to them with a stethoscope. You can see elevated jugular venous pressure with the physical exam, abdominal jugular reflux if you press on their abdomen and look at their jugular veins, S3 gallop, and then certainly peripheral edema, right? For low cardiac output or they're cold, these patients may have tachycardia. They may have hypotension or hypertension, depending on what's going on. More common hypotension. a narrow pulse pressure, so their systolic and diastolic are going to be closer together, more so than normal. We talked about the cold extremities because of decreased perfusion. Pallor, so they're just going to look white and ill, and cachexia. This is Dr. Colhane.
Okay, so we're back to our pathophysiology slide here, and as I said before, we're going to take a look at a version of this graph, okay, that's a little less detailed, and we are going to superimpose a couple of Starling curves on this to kind of see what's going on hemodynamically with patients with heart failure. Oh, thank you so much. Appreciate that, okay? So again, the next slide that I'm going to show you, okay, is a lot simpler in terms of the information on it. But let me get everybody oriented. As I told you, we talked about Starling curves a couple of days ago. There's a ton of different ways to label Starling curves. That's interesting. Okay. Let me see here. Maybe I'll turn that off. That's scary. I wonder if the pointer is on here. Hold on. Well, let's hope it stops moving. Okay, because that's a little freaky here. Okay. At any rate, so if we take a look here at the graphs, right here we've got two Starling curves. This one here, as you take a look at the x-axis, okay, it's labeled a little bit differently. It's ventricular and diastolic pressure. Again, that's preload. Okay, so that is preload. If we go up here, on the y-axis, we have cardiac output. Okay? Now, we're going to start with this one on the left here. Okay? Okay. At any rate, we've got three different curves here. Okay? We've got our top curve here, which is a normal Starling curve. Okay? We've got a curve in the middle, which represents the Starling curve. You know what I think that is? It might.
It's your animation.
It's animation on there. Yeah. So for somehow, it's okay. It's a distracting. I mean, we'd have to go in and edit. There we go. It could be done. All right, maybe it's done. Yeah, sorry about that. Okay, so we've got that middle curve, which represents a Starling curve, a patient with heart failure that's on what we refer to as a drug class called positive inotropic agents. These are drugs that directly stimulate cardiac tissue to increase cardiac output. And we're going to talk about drugs like dopamine, dobutamine, some phosphodiesterase inhibitors that are all positive inotropic agents. And then the bottom curve here is a Starling curve for a patient with untreated heart failure. Everybody follow me so far? We're good? All right, now, we're going to follow the letters here. We're going to start with letter A, okay? So in letter A, we've got a person with a normal Starling curve. They are on this particular Starling curve right at this position, so their cardiac output is good, their perfusion is good, they don't have any type of congestion. They're in that warm and dry category, quadrant, exactly where they want to be. Now, let's say that this particular person has an incident that causes them to go into acute decompensated heart failure. What you can see is that they're going to move from point A to point B. So they go on to a completely different Starling curve. And notice the two curves. This curve is very flat, as I showed you before, right? There's not a lot of cardiac reserve there at all. It takes a huge increase in preload to get any kind of increase in cardiac output, as compared to the top curve there, which is very, very different. Now, when they move to point B here, this patient is in that cold and dry category. So what does that mean? So Dr. Gonzalez talked about this before, right? Cold referring to the fact that because of the low cardiac output, they're experiencing poor perfusion. So their peripheral tissues are not getting enough oxygenated blood. So again, as Dr. Gonzalez said, their extremities can feel very cold, okay? And the dry here means that they are not volume overloaded, so they're not experiencing any type of congestion or edema at that point. Okay, everybody following? All right. Now, what can happen over time is with this low cardiac output, that blood can start backing up, just like if there was an accident on the beltway. All right. And what you can see here is over time, this patient could potentially move up this Starling curve. As that blood backs up and their preload increases and their volume increases in their body, they can actually move up into this quadrant over here, okay, which is warm and wet, all right? So again, as we increase preload, as we increase blood volume, we increase preload, and even in a failing heart, that will tend to increase cardiac output, which you see there. But again, because the heart's not functioning well, even if you're increasing cardiac output a little bit, it's still not enough to take care of that congestion and excess volume that they have. And so they're in this warm and wet category, meaning that they're actually being perfused fairly well, but there's a lot of signs and symptoms of congestion or excess fluid. And Dr. Gonzalez is going to talk way more about that. Okay. Now, one of the things that this graph also shows is that what can we do for this patient here? Well, one of the options, one of them, is to give a positive inotropic agent. And all this graph shows is the consequence of giving them a drug that directly stimulates the heart and increases cardiac output. Okay? So what you see here is that almost immediately, this patient is going to go from point C to point D. Their cardiac output is going to improve because that's what these drugs do. That's what positive inotropic agents do. They very rapidly and quickly increase cardiac output. Okay? And so again, we're still in that warm and wet category, but the patient's cardiac output has even improved more, and they moved on to a better Starling curve, right? They moved from this really crappy Starling curve right here up to this better Starling curve here in the middle, okay? Now, the cardiac output is improved. Over time, the heart can now work to get that blood circulating, eliminate that backup of blood. The kidneys will start to eliminate some of that excess fluid because they're being perfused adequately now, okay? And what you see over time is that preload begins to go down. That excess volume will start to disappear, and hopefully what will happen is your patient will end up back up in the warm and dry quadrant, okay? Now, again, they're still on this middle Starling curve. It's not the best curve, but it's way better than this bottom curve. And we know we'll never get them back to this normal curve up here. But they're happy campers because they're in the right quadrant, okay? They're warm and they're dry, all right? So again, this shows you positive inotropic agents and how they can put a patient on a new Starling curve and actually reduce preload and volume overload. Now, over here shows a couple of different strategies, okay? So here we have our patient. We're starting at point C. This is a patient who experienced acute decompensated heart failure. They started out here in the cold dry category, and eventually, as the fluid in their bodies built up, they ended up over here in the warm and wet category. Okay, now, two other things that we can do for them. First thing is preload reduction. And Dr. Gonzalez mentioned this, right? We can move this patient on this curve to the left if we do things to reduce their preload. And you folks correctly identified that loop diuretics, or diuretics in general, are good preload reducers. They remove excess fluid, they reduce blood volume, they reduce preload, right? Is there another type of drug that we can give that reduces preload without a diuretic effect? The nitrate vasodilating agents, right? So nitrates, if we dilate our veins, right, and we increase venous capacity, that will result in a decrease in venous return, okay, and a decrease in the movement of blood back to the heart, and that will reduce preload. So again, even with a loop diuretic or venodilator, we can move our patient from position C, reduce their preload, and we can get them here to G. And they're in the warm and dry category, just barely, but they're there. Okay, does that make sense to everybody? All right. And then the last strategy is afterload reduction. Okay, so we can use drugs that reduce systemic vascular resistance. Okay, making it easier for that failing heart to move blood through the systemic circulation. Okay, and anything we can do to get that happening will help to improve, okay, the patient's situation. And what an afterload reducer will do, okay, is it will put a patient on a better Starling curve, okay, and eventually you'll see a reduction in preload because the heart's now able to move blood more effectively in the circulation because there's less resistance, okay, and that will result in a reduction in preload, and you'll get that patient again in that warm and dry quadrant. Okay, is everybody following that? So again, we're going to be talking about these three major strategies, right? Positive inotropic agents, preload reducers, afterload reducers, and combinations, I think, of them, right? And so just so you understand how each of those work, and we'll show you specific examples of this when we get there. Okay, any questions? I know every year this is the hardest thing for students to understand. It's tricky. Okay? Any questions that you have at this point? All right, go ahead, Dr. Gonzalez.
All right, some of the laboratory findings that we can get or the patient may present with: elevated brain natriuretic peptide greater than 100 picograms per mil. That's consistent with heart failure and acute decompensated heart failure. Or the pro-BNP greater than 300 picograms per mil. A sodium less than 130, that is considered a bad prognostic sign. Why would the sodium be low in these patients?
Because they're overloaded with fluid.
Yes, volume overload. So that is not a good sign generally. Elevated troponin, maybe if they're coming in with severe cardiac symptoms or consequences from their heart failure. So any type of ischemia, cardiac ischemia. And then for low cardiac output, elevated lactate, again, because of decreased perfusion. If you have decreased perfusion, you can go into anaerobic metabolism. That's going to produce lactate in the body. That is not a good sign. Elevated transaminase from decreased perfusion to the liver. Kidney injury, so we can see this in the increased serum creatinine or decrease in urine output. Metabolic acidosis, that ties into the elevated lactate, right? Hyperkalemia from decreased kidney function. And then a mixed venous saturation. This is another marker of poor heart function, so mixed venous saturation of less than 60. Those would be common laboratory signs for a low cardiac output. Now, these patients can come to the hospital with a variety of different indications. They're going to present in many, many different ways. And this is a nice, somewhat large summary of some of the common causes of indications that they present with. I mentioned like 90% of the patients are going to have fluid overload, right? So they're going to come in with a history of weight gain, a sudden weight gain over days to weeks. They should probably have that or be able to verbalize that. Symptoms of congestion, signs of congestion, so tachypnea, decreased O2 sat, etc. As far as low cardiac output, we talked about these: the fatigue, hypotension, the cold extremities, organ hypoperfusion. So again, renal or kidney hypoperfusion. Brain, decreased perfusion to the brain. Concomitant cardiovascular disease, so uncontrolled hypertension. Remember, that is a precipitating factor. Acute myocardial infarction, valvular disease, arrhythmia. And then other things that could impact hemodynamic status, severe electrolyte disorders, acute exacerbation of pulmonary disease. So maybe they have a COPD and they have a exacerbation of that, severe infection, etc. So as far as classification and diagnosis, this is a similar Frank Starling curve with the congestion here on the x-axis, and then the cardiac index or cardiac output on the y-axis, and then the quadrants. So what do you want to say here?
I think this
a lot.
Yeah, and I think this graph, from my standpoint, because I think you take a look at it looks like the diagnostic indicators over there on the right. I just think when you look at this graph, it's just another indicator of those 4 different quadrants, right? And where you're at on those quadrants will determine kind of what symptoms that you have. Are you poorly perfused? Are you volume overloaded or fluid overloaded? In terms of that over there, the different categories, did you have anything that you wanted to say about that, or can we just maybe put an X through this
Yeah, I think
slide?
we can X this
Let's X
out.
this slide out. I like that. Let's do
It's
that.
more duplicative. So goals of therapy, what do we want to do in these patients? First and foremost, you want to decongest the patient, right? You want to decrease that volume. So we're going to talk about that. You want to certainly improve perfusion. So if they have signs and symptoms of decreased perfusion, we need to improve that for sure. So these 2 things are to stabilize the patient. So you're going to do this immediately when the patient comes in. You're going to look at congestion, try to alleviate that. You're going to try to assess for decreased perfusion and do something with that. And then as the patient is being stabilized, hopefully you're going to identify the precipitating factor. And if you can correct it, that's great. If you can't, then there's other issues. But if the patient comes in with acute myocardial infarction, certainly you're going to try to treat that as best as you can while you're stabilizing the patient. If they have hypertension coming in, severe hypertension, you're going to bring their blood pressure down. That is going to help treat these 2 things as well. And then look at more like chronic therapy after you stabilized and treated the patient. So that's what we're going to talk about. Some non-pharmacologic interventions that we can't forget about. Certainly you want to make sure the patient has adequate oxygenation. So these patients can come in with severe pulmonary edema, decrease in the ability to oxygenate their blood. They will probably need some type of oxygen support, either nasal cannula, BiPAP, etc. But what you want to do, your goal is to keep them above 90% SAT, O2 SAT. Certainly sodium restriction, right? That's important. Sodium restricted diet to less than 2 grams of sodium per day. And then fluid restriction, of course. So restrict fluid intake to less than 2 liters a day. And then if serum sodium is less than 130, you would do that. But in general, you're going to restrict fluid in all these patients. So as far as the pharmacologic therapies, we have 3 classes. That's it. It's very easy, right? Only 3 classes. We have the loop diuretics, which you guys already learned about a lot. So this is just additive for that. We have some vasodilators, and these are going to be intravenous vasodilators. So we're not going to be giving pills to our patients coming in with acute decompensated heart failure. This is all IV therapy. But we're going to talk about some vasodilators. And then inotropic agents to improve that cardiac output. Again, these are intravenous inotropic agents. So some new drugs, and they're all pretty cool, I think. So how to approach the patient with acute decompensated heart failure. This is very similar to the Starling curve graph. You want to identify which quadrant your patient is in. We talked a little bit about this. If they're in cold and wet, you might consider a vasodilator. probably going to consider inotropic therapy. You might even consider vasopressor therapy, like an alpha agonist if your blood pressure is very low. You're certainly going to diurese the patient, right? If they come in cold and dry, you may give them fluid, but in these patients, you have to be very careful because you don't want to increase intravascular volume and cause more harm than good. So you're more than likely going to give them an inotropic agent to push that curve up. If they come in warm and wet, you're going to maybe consider a vasodilator and then diurese the patient to move them over here. So if you guys understand these quadrants, and I said this before, we said this before, when you're thinking about the patient case or seeing a patient on rotations, place them in one of these quadrants, and that will dictate their therapy. It comes together quite nicely based on the pathophysiology of what's going on in the patient. So loop diuretics. All these therapies are going to be IV. So even the diuretics are going to be intravenous diuretics. So we'll give them intravenous loop diuretics for volume overload. That should improve symptoms, and it will reduce morbidity down the road. Diuretic doses should be titrated to reduce symptoms and reduce rehospitalizations. I mentioned on the first slide, the introduction, one common problem with these patients is they get readmitted to the hospital. This could be due to inadequate therapy at discharge, so inadequate control of volume congestion. So loop diuretics in the immediate time period and the semi-acute time period is very important. You had a question?
Yeah. Is there like a standard when you give like a diuretic, is there just like standard volume that you measure for each patient, like a goal for each patient?
Yes,
Okay.
of course. Yes, and we'll get there.
Okay.
We'll get there in like probably about 5 slides.
Okay.
You want to prepare a discharge plan to adjust the diuretics to decrease rehospitalization. And then if inadequate symptom relief and continued signs of congestion, escalate loop diuretic dose or add a second diuretic. So these are just general principles. And we're back here with
with the floating laser pointer. Okay, so again, we're always going to come back to this graph. And look, I'm going to be very honest with you. You will see a graph or two like this on the exam, okay? And asking you, again, what type of drug will move a patient on its Starling curve or move them on to a different Starling curve. So it's really important to understand this. If you're confused, please come and see me. I can get you straightened out. This is, if students get confused anywhere, it's right here. So again, we're talking about loop diuretics. They are preload reducers. They remove excess fluid from the body. That will lower blood volume, and that lowers preload, okay? And we know that, again, on the x-axis, this is a preload. So anything we can do to reduce preload is going to take a patient and move them to the left on their Starling curve, okay? And, hopefully we're going to be able to get them back into this warm and dry quadrant, okay? If you have a patient over here, all right, and they're in really bad shape because they're so volume overloaded that they've stretched the heart out so much that the Frank Starling mechanism is kind of not working anymore. So if you got somebody over here and they're falling off the edge of their Starling curve, you can bring them back up over here by reducing preload, improve their cardiac output, and bring them over in this direction. So preload reducers, like loop diuretics, are really good at changing the patient's position on their Starling curve and improving hemodynamics, right?
Perfect. Awesome. Should we give them a break?
We should. I think I was going to suggest that. That's probably a good place to stop. So let's do 5 to 7 minutes, okay? And I'll give you the 2-minute warning when we come back.
Everything good. I have a question. So if you have like a patient with like traumatic injury and he has like lost his he has depleted body because of loss of blood, and he's like arterial pressure is other than and he has like heart failure. Other than give him, blood transfusion, would you consider like blood resuscitation also?
So there's different forms of shock, right? This would be more like cardiogenic shock.
Oh, okay.
Hypovolemic shock, and then there's hemorrhagic shock. So if they have hemorrhagic shock, they're losing blood. What you want to do is think of why they're losing blood. Identify that. You want to try to stop that. You want to stop that first. The best thing to do is give them blood.
That would be
But
great.
you might not be in a place to give them blood, so then you would give some type of
Well, okay, so they're
like and things like that. So if you're in the hospital and this patient like has a GI bleed, they're losing blood in the GI tract. The hospital has blood, you would get blood,
Any one of
give
those,
them
it
blood.
just depends
Now that
on how long
could
they
take
let it, how long
some time to get the blood to the patient, so then you're going to give them blood.
Oh, okay. But if like the patient has like really bad for example, he's cold and wet in that case.
salty foods, right? Thanksgiving.
Sort of cardiac
Yeah.
So,
Exactly. So that
you're generally not going to
Okay.
generally not. These guys are going to, these patients are going to be, you can actually do more harm than good. So, they have enough intravascular volume.
So
In
again,
fact, they have too much intravascular.
Can you like pull that out from like intravascular volume to help that out, like or
The only situation would be, let's say they have renal insufficiency, or maybe they're a dialysis patient and they miss dialysis. Then you would have emergent dialysis to pull the intravascular volume out.
that just means
That would be
how
a
things
patient
progress.
where you would want
So
to
you
try
can see
to
here with
pull
A.
the fluid out. Other than that, no, you're not.
Okay. Well, thank you so much. I appreciate it.
You,
Ernesto.
nice to meet you. So, email, right?
Yeah. I was gonna introduce myself. I'm currently getting out of like I was sick, so I can't
So
see you.
now we're dealing with the.
I don't want to contaminate you.
But I would be happy to sit down and talk to you.
Of course.
You're interested in cardiology, right?
Cardiology or oncology. Yeah, infectious disease. So I still don't know. I'm interested in that three areas.
So I'm critical care for my whole career, actually. So I did general residency, practice critical care for a long time. Mainly in the medical ICU.
Critical care is another area that I enjoyed when I was doing my rotation.
You get to see infectious disease.
Yeah, like every disease thing. Yeah.
So it's beautiful. I think it's perfect.
Okay.
But you can certainly sit down and talk whenever you have time.
Okay, yeah.
Just shoot me an email and we'll schedule it.
Yeah, because I went through like I'm doing everything I can to do to get into residency and have grades, associations and everything. But I still want to know how to be a good candidate for residency and learn more about it.
And who's your advisor?
Dr. Paul. So Dr. Paul, I'm working with her on other things.
How do you distinguish between the two?
So I'd be happy to review your CV, review your plan, and give you advice on that.
Okay.
I work with plenty of residents throughout my career.
Okay.
I have my own residency program.
Okay.
So,
Okay, I appreciate it. Thank you.
Yeah. Dry just means that your volume status goes to or your DI. Yeah. Yeah.
Lo queremos hacer cuando lo
Yes,
muestran.
exactly.
Yeah.
But low cardiac output. Okay, all right, sounds good. Well, let me re-explain. Okay, and then we will, if you've got questions, we can address that. Shirley, you get it? You understand what I'm saying here? Tori, you good?
Yes.
Okay.
Thank you so much.
Sounds like there might be a little bit So, I think maybe.
I saw a photo of Jessie.
And
Photo of Jessie. Her baby said,
She said she was gonna.
I'm so excited for this to come back.
that's what she
It's like I don't know what to do when she's not here.
Yeah. Or because, maybe because of the, Right, exactly, right, okay, yeah. All right, 2-minute warning, 2-minute warning.
So let's see.
I think we'll definitely do the drugs for sure. Yeah, we're making progress here.
This one, like,
Yeah. Yeah, let's start there. We can start there and we can start. And I think there's, even after that slide, there's one of these too, yeah.
yeah, there's a dilators there. But, so they're confused on
Cold, just what cold and, cold and warm, wet and dry, what that really
Okay.
means. Yeah, and how it's associated with that.
Okay.
All right, we all back here? You guys ready to go? Good. Okay. If you're not, just lie to me. You know that's standard practice, right? Just tell me you're ready to go and lie to me and make me feel
We're ready
good.
to go.
We're ready to go, right?
Yeah.
Oh, I love this enthusiasm, right? All right, so before we get back into it, right, there were a couple of questions at break, I think really good questions about, kind of the Starling graph here and the different quadrants. And what does it really mean when we say cold or warm, wet or dry? And that's really important because, again, as Dr. Gonzalez said, that's one of the first things you're going to do, right, is try to figure out, what the fluid status of the patient is and what their cardiac output looks like so that you can place them in one of these quadrants, okay? So again, from my perspective, okay, just from a physiologic perspective in terms of what's going on, okay, when we say someone is cold or warm, okay, that can tell us something about how well their heart is pumping blood throughout the systemic circulation, right? If they're warm, okay, their little fingers and toes, right, are getting lots of good blood supply, so you got warm hands and warm feet, right? Your kidneys are getting lots of blood, your other organs are getting lots of blood, and that's what you want to be, right? You want to be warm, you want to have good blood flow to all parts of your body. All right, everybody following there? We're good, okay. When you're cold, okay, essentially what that means is you're not getting enough blood flow to peripheral tissue. So you've got cold, you'll see like cold hands, right? Your feet will be cold. I mean, sometimes we're all experiencing that in the wintertime, right, where you've got cold feet or cold hands. But, even more importantly, some of those internal organs, like your kidneys, aren't getting enough blood because your heart isn't strong enough to get that blood to the kidneys or to the peripheral tissues. Okay? All right? And so that's we refer to that as hypoperfusion, right?
Yes.
Okay? All right, and that can be a real problem, right? When your organs, your tissues aren't getting enough oxygenated blood, that can be a real concern. All right? So cold and warm, which one's good?
Warm.
Which one's bad?
Cold.
Good. Are we good there?
Yes.
Okay, you want to add on to that, cold and warm.
You can see this on the slide. So this is a great slide.
I love it. This is a great slide, yeah.
So for well perfused up here on the cardiac output, right, you have in green. Green is good. Warm extremities, adequate urine output. That means the kidneys are working. Preserve renal function, normonatremia, so your sodium level is fine. For cold, cold, you have cold extremities, oliguria, meaning you have decreased urine output. Your kidney function could be depressed, and then hyponatremia. So you have some signs and symptoms here that you should be able to associate with a cold patient or a warm patient.
Yeah, that's great. So as you're looking at it, I would assume as you're looking at a patient in the hospital, you're looking for these sorts of things to make a determination about perfusion status.
Yes.
Are they warm or are they cold? Are we good? Okay, now let's move on to the wet and dry. Okay? So again, everything's on a spectrum here. So on the x-axis, what we've got is preload, right? Which again can be a reflection of blood volume and the amount of fluid in the bottom. That can directly impact preload. We know that, okay? So again, over here on this side, we've got patients that are dry, meaning that they either have kind of normal fluid levels in the body like us right now. Hopefully we're all pretty dry right now. Me not so much because I just drank all that Mountain Dew, okay? But over here, if they're wet, that means that they have fluid buildup throughout the body. And that fluid buildup is due to a couple of different reasons. Number one, the failing heart. If your heart isn't adequately able to continue to move blood through the circulation, right? Okay? And blood starts to back up into the lungs and into the peripheral tissues. You'll have water that will start to leach out of the capillaries and into the lungs and surrounding tissue. Okay? And once that fluid starts to accumulate, okay, they're kind of sloshy, and we consider them wet, right? Okay, the other reason for that is if the kidneys aren't getting enough blood, they're not able to filter the blood very adequately. As Dr. Gonzalez pointed out, right, their urine production goes down, so the body's holding on to a lot of excess water. And all these combination of things will make them wet, all right? All right, now, which one's worse, right? We certainly don't want wet, right? Wet is not good. Warm or wet, cold and wet, not good. Okay, we want to get rid of that excess fluid. Okay, but also, I would imagine we don't want to be too far dry either, right? Because that can cause hypotension.
Yes.
Okay. Okay. So again, there's a balance with regards to, I think, the fluid status of our patients, as Dr. Gonzalez said, right? Okay. And again, our goal is to get them up into that warm and dry quadrant, right? So that they're nice and happy campers. Okay? Everybody understand that. And there's a lot of different ways pharmacologically that we can move patients from one quadrant to another. Go ahead, Hazel.
I'm looking at the sixth slide, which is talking about what is acute decompensated heart failure. By definition, it says typically related to systemic congestion. So what do we mean by congestion when we are talking about dry?
So congestion is wet. So systemic congestion would be just too much volume on board, both intravascularly and extravascularly. So the patient has too much volume.
Okay, so that was where I got my confusion, because I've been looking at heart failure as having to do with congestion, which is as a result of the fact that it's not being pumped out. So when I start saying dry, I'm asking myself, is this still coming as, does this still qualify to be compensated heart failure? If it's dry, can we still say it's decompensated heart failure? Or should we just call it heart failure but not decompensated?
So did you get the question?
Yeah,
If you look at 6, you'll see where my confusion is.
And you're talking about they're in this quadrant right here,
Yes,
Kinsley?
the we still call them decompensated heart failure in that case?
Yes, because they don't have adequate perfusion, right? Their cardiac output is down. And this is rare for them to present in this quadrant here. But if they did, their cardiac output is impaired. They don't have adequate perfusion. Perfusion to your vital organs is very important, right? You want to perfuse your brain, every other organ, your liver, your kidneys, etc. So they may not be able to perfuse your vital organs here. So that would still be a serious consequence. And look at this, their mortality is like 23% in this quadrant. That's an estimate, but it's a very high mortality because you don't have adequate cardiac function. That is not a good thing for living. So you want to preserve that heart function or to improve that heart function, again, to put them up into that quadrant there. So they could come in wet, and then you may push them to this quadrant, but you still have an issue with the perfusion part, right? Does that make sense?
I understand. Okay, go on. Kristen, go on.
So when we get a case, we're always gonna use the 2.2 and 18 as a point of reference to where we have to locate where is the patient.
Did you guys talk about what question?
We did not.
No. Okay, good.
And I would just, frankly, from my past experience, we don't necessarily see, we're not using those kind of numbers. The way I've seen clinical faculty in the past, in their cases, really use more symptoms. Like describing the patient. The patient comes in with pulmonary and peripheral edema, and their blood pressure is low. Okay, so what quadrant do you think that would put them in? If they have low blood pressure and they've got pulmonary edema and peripheral edema.
Okay, hold on, right?
Right, am I right about that, Dr. Gonzalez, right? Okay, so again, those kind of descriptors, okay, are going to be what you would use to kind of determine what that is. Can I ask you a question?
Yes.
Do they do these kind of measurements in heart failure patients like pulmonary?
Yes.
Okay, so they'll insert the catheter and then,
Yes.
Okay, cool.
It's cool. It's really cool. But for the purposes of our discussion, your learning, you don't have to know pulmonary capillary wedge pressure. You don't have to know these numbers here, okay? Just have an understanding of these quadrants with the Frank-Starling curve. Volume or preload on the x-axis and cardiac output on the y-axis, okay? That's what we want you to comprehend. And for next year, I'll delete the pulmonary capillary wedge pressure. So that's more advanced. Like if you went on to rotation with me, we'd certainly talk about pulmonary capillary wedge pressure, cardiac index, and it's all great stuff. But that's more advanced. Great question. Any other questions before we move on to loop diuretics? Awesome. All right. So again, they're going to present majority of the time wet. You're going to be wet. So you're going to diurese them, right? Initial IV, intravenous loop diuretics the dose should be equal or to exceed their chronic daily dose. So these patients are going to have chronic heart failure. They should be on some type of diuretic, right? And that diuretic dose that you're going to give them, IV form, is going to be at least equal, but better to be 2 times their chronic heart failure dose. So that's what we would start with, at least 2 times their home diuretic dose given IV or parenterally. You want to bolus this dose. So in the hospital, you can administer these drugs intravenous as a bolus or a continuous infusion. You want to bolus these diuretics first because you want a quick onset of action. And the data suggests that bolus therapy is the same as a continuous infusion. If you did a continuous infusion, you would still need to bolus the patient first to get them a loading dose to get them enough concentration for it to act quicker before you start a continuous infusion. So the purposes of your guys' learning, you want to know this 2 times their home dose and to use bolus therapy. You're going to titrate the dose based on a net negative. We had a question about that earlier. So your goal negative would be 1 to 2 liters a day. What does that mean? That means their urine output should be negative. So what's coming in should be less than what's coming out should be more than what's coming in. So 1 to 2 liters, that's a lot of fluid, right? But you want to diurese these patients to eliminate as much fluid as you can, and up to 1 to 2 liters per day. Certainly you're going to be monitoring symptoms, right? So as you diurese these patients, you should be able to tell the clinical effect as far as symptoms, improvement of symptoms. If you have inadequate response, meaning that their symptoms aren't improving or you're not getting to this goal, then you could double the dose at every 2-hour intervals. So if you start off with furosemide at like, say, 20 milligrams, and you don't get the response that you want, you're not diuresing the patient, their urine output isn't picking up, wait 2 hours and then double the dose, so give them 40 milligrams. Onset of diuresis, generally within 30 minutes, peak effect about 1 to 2 hours after administration of a bolus.
So the patient comes in and his home dose was furosemide 20 milligrams. That was his home dose because it was chronic. When he comes in, the first bolus is going to be 40.
Yes, equivalent dose would be 40 milligram IV.
As a bolus dose.
As a bolus.
If it doesn't respond after 2 hours, we make that 80 milligrams?
Yes.
Okay. Hypothetically, it still doesn't respond after 2 hours, we make it 160 milligrams?
And,
what point do we stop?
And we'll get there. Great question. Because your patient may get there as well. If you're not seeing adequate response, you can add a thiazide diuretic to your loop diuretic to augment the diuresis.
Remember, they work at different spots in the nephron, right? So you can use them synergistically. Yeah, that's really great. Yeah.
Efficacy. So certainly volume reduction, right? We want these patients dry. So you want to reduce volume. So volume reduction is one of your things that you're going to look for. Decrease congestion, so clinical improvement in the patient. Again, they act as preload, so they may actually improve perfusion, right? By decreasing preload, that can increase cardiac output. Safety, there's certainly a risk of hypotension because you're decreasing their volume. These patients may be tenuous at baseline to begin with. So you kind of have to be a little bit careful. Certainly a reduction in serum electrolytes. And which one of the electrolytes are we most concerned about with loop diuretics? Potassium, possibly sodium, certainly potassium. You may see an increase in serum creatinine if you over-diurese them, if you make them too dry, too quick. You can see an increase in serum creatinine. So you want to be careful with that. And that would be because it reduced intravascular volume. And then here we go. Like I said, if they're on that cold segment, you want to be careful about giving a diuretic until they're perfusing well. So if they're cold and dry, you generally aren't going to give a diuretic. And if they're cold and wet, what you want to do is augment the perfusion first and then diurese them. And sometimes this is going like hand in hand, like happening at the same time. Other adverse effects, you probably talked about maybe ototoxicity.
Yeah. Did you want to mention anything about rate of infusion and ototoxicity? Because
Yes.
we did not talk about that with chronic.
Yeah. So with ototoxicity, it's really going to be related to rate of infusion and possibly dose, but more rate of infusion. And if you think about the where it's causing the ototoxicity in the inner ear, if you bolus it in very quickly, you're going to get higher concentrations in the inner ear. So they could develop tinnitus, so ringing in the ear, or actually hearing loss. Unfortunately, this is very difficult to identify in a hospitalized patient. We don't routinely do hearing tests. So this is something that we're probably going to see after the fact. Unfortunately, it may be temporary, so it may go away over time. So this is, going back to your question is, well, when do you stop? So if we talk about furosemide, what I want to point out, first of all, is that there's an IV to PO ratio of 1 to 2. So your IV dose is generally 50% of your oral dose. So when they're on 20 milligrams of oral furosemide, you're going to double that to 40 milligrams of oral furosemide, which is equal to 20 milligrams of IV furosemide. Does that make sense?
Yeah.
So the IV to PO ratio, the IV for furosemide is generally 50% of the oral dose. Now, remember, in these patients, you're going to double the dose, so it's going to be almost equal to their oral chronic therapy. But initial daily dose, generally, if they're not on furosemide, is 20 to 40 milligrams, up to 160 milligrams daily to BID every 12 hours. With bumetanide and torsemide, the IV to PO ratio is 1 to 1, so it's the same. And then you have the upper limit of doses there in the usual range. For the most part, your patient is going to be on diuretic therapy when they come in. So you're not even going to have to look at this. You're just going to have to remember twice the chronic dose. And then you're going to have to look at, okay, what's the maximum dose that we could give the patient? Does that make sense? Any questions?
Just to follow up with Kingsley's question. Since you look directly like bumetanide is more potent, so the patient comes with furosemide, can you just like compare and switch to a more potent one than keep increasing the furosemide?
Great question. That kind of leads us, look at you guys are like thinking ahead, right? That leads us to diuretic responsiveness. So you can, and it's right here, switch to bumetanide, furosemide from furosemide. You can do that. That is one of your options, yes. If you're not seeing effect of that furosemide. So let's say, I would say 99% of these patients are going to be on furosemide at home. You're going to try furosemide in the hospital. It's cheaper than bumetanide or torsemide. So you're going to try that until there's no effect. You're going to go through the path by doubling the dose and thiazide diuretic, and if you don't have an effect, you can certainly go to another loop diuretic. But because of price considerations, generally these are reserved for resistant patients. Reasons for unresponsiveness would be NSAIDs for sure, right? We want to avoid those in these patients acutely and chronically. Consumption of large quantities of dietary sodium, that would be another precipitating factor, of course. But if they did that before they came in, they may be more resistant to diuretics in the hospital in that acute phase. And then there's diuretic resistance. And then significant renal impairment. Remember, when you have degrees of renal impairment, as you get along the spectrum of renal failure, it's going to be much harder for these drugs to work. So you're going to generally need higher doses to see a clinical effect. So combat resistance, increase the dose of IV diuretic to the maximum dose. You can switch from intermittent bolus doses to continuous infusion, which I alluded to before. That seems to help in a lot of these patients. You still need to bolus first and then start the continuous infusion. And then add a thiazide. That can be actually very helpful in these patients. So you would add something like metolazone chlorothiazide, or switch to bumetanide or furosemide. Any questions about loop diuretics? Excellent. All right. So vasodilators. So really what our therapeutic benefit is, again, the relief of dyspnea and that pulmonary congestion. Vasodilators have no impact in outcomes. There's been multiple studies looking at this. There's no impact. It's all clinical benefit, symptom relief, which is still very important, of course. So they will decrease venous tone, decrease preload, and or decrease arterial tone, which is afterload, depending on the agent, right? Places in therapy, so you're going to add this to IV diuretic therapy to help improve dyspnea. It may be especially helpful in a severe acute pulmonary edema. So if you have a patient who comes in the hospital with severe acute pulmonary edema, a vasodilator is extremely helpful in that situation. And there's no effect on rehospitalization or mortality. When to avoid? If they're preload dependent, we're not going to go into exact causes of preload dependent here. Again, I think that's more advanced, but because they're preload reducers, if you reduce their preload, you can actually cause more harm than good and cause a decrease in cardiac output very quickly. You want to avoid them if they have some degree of hypotension, so systolic blood pressure less than 90, or are hypoperfused to begin with. You want to avoid them. So certainly you're going to monitor blood pressure and then symptom improvement in these patients. Do you want to?
Yeah. So and maybe what I'm going to do you mind if I go back to the other diagram?
That's fine. Yeah.
Because I think that'll be a little bit easier just to show everybody. Okay. And I think here too, okay, this is another Starling curve. It looks a little scary because there's a lot of different things on here. But you can, again, look up here and,
Sorry.
That might have been, was that me or was that you?
That was me.
Okay.
Which one do you want?
The 27, slide 27.
Okay.
Yeah. Okay. So again, as Dr. Gonzalez said, and I think this is really important when we talk about vasodilators, right? Okay. We've got drugs that have got mixed vascular function, as Dr. Gonzalez pointed out, right? They will cause venodilation, but they also cause dilation of arteries. So like our nitrates are really good examples of this, okay? So if we go over here, okay, we take a look at our patient here at C, okay, we can see again what both of those types of effects will have, okay? The preload reducing, okay, can help move the patient, to the left on their Starling curve. Afterload reduction helps to put them on another Starling curve. And the point of the fact is that they're moving to the left and up, which is important, right? So you're reducing afterload, making it easier for the heart to move blood through the systemic circulation. That improves perfusion, right? And when you dilate the veins, okay, you increase venous capacity, you reduce venous return, and preload starts to go down. And those are two things that we want to be able to accomplish in patients, certainly with heart failure. So again, just understanding, again, these are two things that can happen here with preload reducers and afterload reducers, okay? And as you can see from that particular graph that Dr. Gonzalez had there, this can get really wild and complicated here, right? So it's if you love cardiovascular stuff like I do, right? This is a great area to get into heart failure management, as Dr. Naeem said. Yeah, there you go.
Thank you. So the first vasodilator we're going to talk about is nitroglycerin. And it's a preferred vasodilator for preload reduction. It's a venous dilator. So it's going to work primarily on the preload because of the venous dilation. You can see some other beneficial effects: coronary artery dilation, etc. Your dose is going to be generally start at 5 to 10 micrograms per minute as a continuous infusion. So they're going to receive this in their vein as a continuous infusion. And then you're going to titrate up to a maximum of 200 mics per minute. And it can be titrated relatively quickly. The onset of action is immediate, generally. So once you get it into their vein, you should see some clinical effect pretty quick as far as hemodynamic effect. Half-life is 1 to 4 minutes, so you can actually titrate this up relatively quick. As far as monitoring, certainly you're going to clinically monitor their symptoms, right? So if they're fluid overload, too much volume, what's one key monitoring parameter that we want to look at? Urine output? Possibly. That would be more for perfusion, I would say. Respiration. So remember, these patients probably will have pulmonary edema, right? That can cause difficulty in breathing. So respiration, their ability to oxygenate, their comfort level as far as breathing, those are all clinical signs and symptoms that you're going to monitor. Excellent. So respiratory rate hopefully will go down. They shouldn't have that difficulty in breathing type of feeling as you decrease volume or decrease preload. Side effects would be hypotension, right? It is a preload reducer, so it could decrease your blood pressure. Some CNS side effects, dizziness, headache, could cause flushing as well because of vasodilation. Now, importantly, with the nitrates, and you probably learned about this in chronic heart failure, they can cause tachyphylaxis. So you may see tolerance develop after you use this a day or two, 24 to 48 hours. You can see tolerance develop. So you might have to increase the dose if you see tolerance to the maximum dose, of course. So you can override some of that tolerance by increasing the dose if you have room to go up on it. Yep.
After we dilation and reduce the pulmonary congestion, where does the fluid go to? Is there like with peripheral edema that is caused then?
Great question. Great question. So after venous dilation, what happens to the fluid basically, right? So what you're doing with the nitrates is you're decreasing preload. That is going to have better, your heart is going to have better ability to have filling pressures, adequate filling pressures, and increased cardiac output because it's not overloaded, right? So you're going to have more time for adequate filling pressure to have improved cardiac output. So that fluid is still going to be intravasculature and peripherally systemic, and that's why you still need diuretics in these patients. Yeah, great question. Sodium nitroprusside. This is a second agent that we're going to talk about as far as vasodilators. Sodium nitroprusside is a very potent arterial vasodilator. So it's going to reduce preload and afterload. Certainly as you go up on the dose, it's going to have more effect on afterload. Dose here is 0.1 to 0.3 micrograms per kilo per minute. So it's going to be dosed based off of weight in kilograms. Make sure you know that. Whereas nitroglycerin is not dosed by weight. Maximum dose of nitroprusside is about 5 micrograms per kilogram per minute. Monitoring, again, because it's a very potent vasodilator, could see hypotension. So you want to be careful with titration of this, even though it has a quick onset of action, has a very short half-life as far as the parent compound. You want to go up a little bit slower than nitroglycerin. It's a stronger vasodilator. Because of that, you generally want arterial line to monitor blood pressure in your patient. So you're not going to monitor blood pressure off of a cuff. It's going to be an arterial line to help give you that minute by minute, second to second monitoring of blood pressure. And then the cyanide toxicity. So it has thiocyanate, which is excreted by the kidneys. So especially in patients who have decreased kidney function, this can accumulate and cause issues, mainly metabolic acidosis and hyperoxemia, some tinnitus. More related to prolonged infusions of nitroprusside and higher doses and or kidney dysfunction. I would have to say it's very rare, but you're going to hear about this whenever you use nitroprusside. So as far as the two different agents, you want to know nitroglycerin reduces preload, nitroprusside reduces preload and afterload. You want to know some of the adverse effects, be somewhat familiar with the dosing scheme. One is dosed by weight, one is not dosed by weight. That would be important. How to pick between these two? I would say if you're using diuretics, loop diuretics, and they're not improving as far as their congestion, you generally are going to go with nitroglycerin. If they come in with the blood pressure problems, nitroprusside is very good at reducing the blood pressure. You're going to probably choose nitroprusside, not nitroglycerin. So if they come in with very high blood pressures, you're going to go more toward nitroprusside because that arterial vasodilation is much, much stronger. So those are your key clinical pathways, I guess. Generally, you're going to use nitroglycerin if you're not seeing an effect with diuretics.
And this nitroglycerin is added on top.
Yes, great question. So you're still going to diurese the patient, continue diuresing, and then if you're not seeing clinical effect, you're going to add this on top of it.
But if the patient came in dry, we will not do the diuresis, we just go straight to nitroglycerin.
So they're generally not going to come in dry. 90% of the patients are going to come in wet. They may be warm and wet, they may be cold and wet, but they're going to be wet. So if they're over here on that quadrant, either you've already given them therapy to decrease them, to move them from wet to dry, but they're still in that decreased perfusion quadrant, and you wouldn't use a vasodilator there. So if they're cold and dry, you're not going to use a vasodilator. And we'll get to that segment here. So if they have inadequate cardiac output, so they're cold. It could be cold and dry, cold or wet. They may have cardiogenic shock. So clinical criteria for cardiogenic shock would be a systolic blood pressure of less than 90, so not adequate blood pressure, or a MAP of less than 60. These are both for 30 minutes, or a need for vasopressors, maybe an alpha agonist or some sort, to maintain the systolic blood pressure of greater than 90. So if you see that in your patient, so their blood pressure is low, either by MAP, mean arterial blood pressure, or systolic blood pressure, they may be cold. You're going to have clinical signs and symptoms to help you determine if they're cold or not as well, right? We talked about cool extremities, maybe increased lactate, metabolic acidosis, decreased urine output. Those are all clinical signs and symptoms of someone with a decreased cardiac output. So you're going to have all that data to determine if this patient is cold. If they are, then you're going to go more to therapies that will augment the cardiac output. Does that make sense? Severity of congestion and adequacy of perfusion should be assessed to guide triage and initial therapy. These are the guideline recommendations. So diuretics should be titrated to resolve clinical evidence of congestion. And then intravenous inotropic support should be used to maintain systemic perfusion and preserve end organ function. So again, in patients who are cold, they have decreased organ perfusion. That's not good. We want to provide adequate organ perfusion. So they're perfusing their brain, their vital organs like their kidney, lungs, liver, etc. We're not going to talk about mechanical support. So inotropic agents will increase cardiac output. So you're going to move the patient on that cardiac output curve up. Or if they're over there, you're going to push that curve up into that, hopefully, left upper quadrant. They will improve perfusion, right? Because you're increasing cardiac output. So you will increase the patient's perfusion and hopefully maintain end organ perfusion or function. Placement therapy, they're for short-term management. They can be considered in symptomatic hypotensive patients, so again, less than 90, or signs of hypoperfusion. They may be used in patients with fluid overload, not tolerating IV diuretics due to worsening renal function. And they may be required to maintain cardiac output to improve symptoms in end-stage patients, so like palliative patients. Most of the time, it's going to be this first bullet there. So the patient who is hypotensive and not perfusing, that's when you're going to consider them. It's important to note that long-term use, they've been doing a lot of studies with inotropes. Long-term use is potentially harmful and has led to increased mortality. So we can't let these drugs go for days to months, and then those studies have been done. Just like nitroprusside, you're going to use a continuous monitoring, hemodynamic monitoring in your patient, and periodic EKG, because these agents can be arrhythmogenic. They can cause myocardial ischemia. You're increasing the work of the heart, so that could cause myocardial ischemia in some patients, and some may cause hypotension. So you're going to monitor blood pressure, side effects, myocardial ischemia, and arrhythmias.
Oops. All right, so a couple of things here before we get into this, because we've got about 5 minutes left. I want to make a suggestion. So we're pretty close to the end. Okay, we're not going to finish before 3:20. But I would like to suggest that we continue just so we get the Panopto recording. Okay. Because we'll be another maybe, 10 minutes maybe after, 10, 15 minutes. If you need to go, please go. Okay. Or if you've had it, you need to go. You're not going to hurt our feelings one bit. Okay. We just want to do this to get the recording. If you want to stay, you can stay. Okay. But we want to respect your time. We know class ends at 3:20, but it's just easy for us to get the Panopto recording this way. Okay. Sound good? All right, great. So let's talk about positive inotropic agents in general, okay? We're talking about over here, this particular Starling curve, all right? And again, this is a curve that I have to work with that I got from your textbook. So in this particular example, we have someone who's in this upper right-hand quadrant. They're warm and wet, and they're at position C on their Starling curve, right? So Dr. Gonzalez said, these drugs directly stimulate the heart and improve cardiac output. So what you're going to see is a fairly rapid increase in their cardiac output. That's why they go straight up. And in fact, they get put on a brand new Starling curve. Okay? And as the heart begins to function more effectively, your kidneys get perfused, right? We may be using other drugs along with this as well, like diuretics. What you'll hope to see is that over time, okay, that you get elimination of excess fluid that reduces preload, and we hope to end up, as you pointed out, in this upper left-hand corner. Now, our positive inotropic agents, we're going to see we've got dopamine, dobutamine, we've got phosphodiesterase inhibitors. They all directly stimulate the heart. Okay, 2 of them work directly on beta receptors. The other one works on beta receptor signaling pathways. And we're going to go through that, and Dr. Gonzalez is going to talk about their unique therapeutic use, okay? I guess I'll go first, yeah. So dobutamine, okay? So dobutamine is an interesting drug. It was developed in the mid-1970s as an alternative to a drug that had been used for years prior to that, and that's dopamine, and we're going to talk about that next, okay? Now, dobutamine is really interesting. Here's the chemical structure here. It's got that classic catecholamine ring over here that you see in like epinephrine and norepinephrine and dopamine, okay? We've got a terminal amino group right here. We've got a functional group on the terminal amine, but it lacks that aliphatic beta hydroxyl group that we see in like epinephrine and norepinephrine and those sorts of things. Those are also direct agonists. Thank you, sir. Now, the racemic mixture here, both enantiomers have different pharmacological effects, and this is super important, okay? If you are like totally lost or totally, just exhausted, and you don't have anything else, what I want you to remember here is that overall, dobutamine stimulates beta-1 receptors on the heart, and that's what gives you the positive, ionotropic and chronotropic effects of it. That's what improves cardiac output, okay? It also directly stimulates beta-2 receptors. Okay, and we find beta-2 receptors in things like skeletal muscle vascular beds. Okay, what's that? Lungs, right? Well, and we're talking about bronchial tissues and things like that. But what we see is a reduction in afterload with the beta-2 effects. Okay, so dobutamine, if you don't want to hear the rest of the story, it's a beta-1 and beta-2 agonist. The beta-1 component stimulates the heart directly to increase cardiac output. The beta-2 agonist component of it actually reduces afterload by dilating various vascular beds, okay, in the body. Now, one of the other things, again, that I was going to go into a little bit more deeply is that both the positive and negative enantiomers have opposite effects on alpha-1 receptors. And essentially, those effects cancel each other out, okay? And so there's no alpha-1 effects. It's really just beta-1, beta-2 agonism, okay? All right? So just remember, don't worry about the alpha-1 effects canceling each other out. Just know beta-1 and beta-2, okay? And then let me see what's the next slide here. I don't know. I think that's yours.
That's mine.
Yep. Okay.
Thank you.
Yes.
Does it have both inotropic?
Yeah, they're inotropic and chronotropic, so they both increase heart rate. Yeah, of course, contraction. Yeah, that's the beta-1 effect. The beta-2 agonist effect causes a reduction in afterload. Okay?
Great question there. So therapeutic effect, you're going to increase myocardial contractility, right? You're going to improve cardiac output. That's your goal with the inotropes, to improve cardiac output, to improve perfusion. So that's what you're going to do with these agents, and specifically dobutamine. Like Dr. Calhoun said, it may decrease systemic vascular resistance at lower doses. The dose is 2 to 5 mics per kilo per minute. Again, this drug is dosed by weight, so you have to know that, up to a maximum of 20 micrograms per kilo per minute. Monitoring, you're going to monitor increased contractility. So any clinical parameters of contractility or improved perfusion, you're going to monitor in your patient. Cardiac output, stabilize heart rate, stabilize blood pressure. You're going to monitor those. Toxicity, not that much. It can cause hypotension because of those beta-2 effects, especially at larger doses. So certainly you want to be aware of that. You may see some tolerance over time, but generally not as much as nitroglycerin. Very quick onset, and half-life is short, so it's readily titratable. So you could titrate up that continuous infusion.
Okay, so we've got dopamine here, and dopamine is a much older, again, positive inotropic agent. We had digoxin before that, but we don't even use that anymore. Dopamine, again, you'll recognize that name because it's an endogenous catecholamine. Your body makes it. And it has both cardiac effects and vascular effects. We can use it exogenously to kind of mimic what's going on in the body and help to improve cardiac function, okay? It is, again, ineffective orally, so this is just IV, all right? We can go to the next slide really quick. What's really, again, tricky about dopamine, and I think it's one of the reasons why dobutamine was created, is that, and Dr. Gonzalez can talk about this as well, I mean, the effects are dose dependent, okay? So at very low doses, okay, you can get a little bit of D1, dopamine 1, and dopamine 2 receptor activation, and that will dilate splanchnic and renal vascular beds, so you get vasodilation there. As you get up to the kind of 2 to 10 micrograms per kilogram per minute range, you add on top of that beta-1 activation. So again, this is a positive inotropic effects of the drugs. It will increase cardiac output. Okay, it also increases heart rate. Okay. And then, again, towards the higher range, okay, of this dose range, you may start to see an increase in vascular resistance. And again, that's probably due here again to the effects of this drug at 5 to 20 micrograms per kilogram per minute, which is where you get alpha-1 activation and an increase in systemic vascular resistance, okay? So again, it's kind of a messy drug. The effects start to accumulate as you increase the dose of the drug. So again, calculating doses, and I can't even imagine how difficult this is to manage. Good luck here. I'll give that to you. Okay.
So dopamine is not the preferred agent in cardiogenic shock, and it's mainly because there's some studies showing an increased mortality and increased morbidity, mainly because it's a pro-arrhythmic, right? Because of those beta effects, very strong beta effects, you can see some certainly tachycardia and other arrhythmias in your patients with dopamine, especially as you go up on the dose. We already talked about these dose thresholds, so you should know that it's dose dependent and what effect you're going to see at higher doses. Monitoring, similar to dobutamine, you're going to monitor output, cardiac output, right, and perfusion. So very similar amongst the inotropes there. Specifically with dopamine, the tachyarrhythmias and overall tachycardia. That could cause some problems in your patient, and it's generally not used. So it's not going to be your first line drug to choose in a patient. Very quick onset and half-life. So again, this drug is really titratable. It's a continuous infusion.
Can you go back to the last slide really quick? Yes, right here. There's a typo there for those of you on Panopto in there. If you see at the high doses down here, okay, it should be increases after load, not reduces.
Yes.
Okay, and that last line there, okay? And again, I think the dose ranges are pretty close to what you and I have there. Whatever doses Dr. Gonzalez gives you, that's what you should go with. That's just a general guideline for me, okay?
Yep, and we'll fix that on the slide and post the new version of the slides. I would say these thresholds are relative.
Yep.
So certainly you can see some beta-1 activation here and some pro-arrhythmic effects. So just know that every patient's different, right? They're going to react to this differently. But for purposes of your knowledge, be aware of these thresholds.
Yeah.
Phosphodiesterase 3 inhibitor therapy, milrinone.
Yeah, milrinone. So this particular drug, I've got the chemical structure up here. There is no medicinal chemistry or structure activity relationships that I want to talk about. But if we go to the next slide here, okay? So this drug will directly stimulate cardiac tissue to improve cardiac output, but it has a very unique mechanism of action. You guys have talked about phosphodiesterase inhibitors before, right? Where have you talked about those before? Have you talked about them at all before? Don't remember? All right. Well, at any rate, let me show you, okay, we're just very quickly right over here, okay? This is a cardiac muscle cell, okay? And you take a look over here, you've got a beta-1 receptor. Now, drugs like dobutamine and dopamine will tend to activate this receptor, and that's why you get the positive inotropic and chronotropic effects of those drugs. Milrinone is very interesting. It actually works downstream in the beta-1 receptor's signaling pathway. So we know that beta-1 receptors in heart tissue are coupled to adenylyl cyclase, and adenylyl cyclase makes cyclic AMP right here. And again, as cyclic AMP accumulates in the cardiac muscle tissue, you get activation of protein kinase A, which will phosphorylate and activate a calcium ATPase pump on the sarcoplasmic reticulum inside the cell. We talked about this in module 1, okay? And it really helps the cell to hyperload with calcium and have access to extra intracellular calcium, which again will increase cardiac contractility. So a drug like milrinone, here's an older drug, amrinone, that's no longer used, but it works the same way. Blocking this phosphodiesterase enzyme, which breaks down cyclic AMP, okay? And that helps cyclic AMP to accumulate even further inside the cell, and that will lead to increased activation of PKA and increased phosphorylation and activation of the calcium pump that you see down there. And you'll get an increase in the loading of calcium in the sarcoplasmic reticulum, which can be used in subsequent cardiac cycles to improve contractile protein activation and contraction, okay? A couple of effects here. It's positive inotrope and chronotrope, okay? It also can cause vasodilation and reducing afterload, okay? And it also increases the speed at which cardiac muscle tissue relaxes. So it's got a lusotropic effect. Okay, and so that can be effective in terms of, again, improving cardiac filling time, I would imagine, right, and improving function. So,
Thank you. So the
signaling there for you guys. Sorry about that.
All right. The therapeutic effect, again, you're going to increase cardiac output, right? That's why we were using these inotropes. So increased myocardial contractility and cardiac output. As previously stated, it may decrease systemic vascular resistance or afterload at lower doses. Again, this one is a continuous infusion, dose by weight, so 0.125 to 0.25 micrograms per kilo per minute. The most important thing with milrinone is that you have to reduce the dose in renal impairment by a significant amount, so 50% in renal dysfunction. And the maximum dose changes, it actually is 0.75 with normal kidney function, and with impaired kidney function, it's 0.375 micrograms per kilo per minute.
Will this be used in conjunction with nitrates?
With the vasodilator?
Yeah, the nitrates. You know, we talked about the nitrates now. We said we could put the nitrates on top of the diuretics.
Yes.
Now we're talking about this. Is this going to be on top in addition?
It can be, yes.
Whether there's a contraindication between PDE inhibitors and nitrates.
Why don't I didn't hear the last part.
I thought we have a contraindication between PDE inhibitors and nitrates.
That's for acute therapy, no.
That's the PDE5, I think.
Yes, it's PDE5.
PDE5, not PDE3.
Right.
No.
And that's because that can produce, I believe, just a pronounced vasodilation. So the combination of that. So in the acute setting in the hospital, remember, we're monitoring hemodynamics. That's an excellent question. But in the hospital, we're monitoring hemodynamics. So we're reassessing the patient like minute to minute. And so we're going to hopefully be on top of those effects. But yes, you can use these agents in addition to vasodilators and diuretics, depending on what's going on as far as the pathophysiology of the patient. Monitoring is the same for efficacy. So for inotropes, you're going to monitor the same thing across the board. Okay, it's easy. Similar to dobutamine and dopamine, you're going to see tachyarrhythmias with milrinone. So that would be one adverse effect. possibly hypotension because of the venous dilation. Now look at this. The half-life of milrinone is much longer than dobutamine or dopamine. It's in hours. So once you start this drug, if you stop it, the clinical effect is going to persist, especially if the patient has renal dysfunction. So in normal renal function, it's about 2 hours, which is a relatively long time. So you want to be a little bit careful titrating this drug. It's not as titratable as dopamine or dobutamine. This is a nice comparative table that goes over all the inotropes. Certainly you want to know the adverse effects with the individual inotropes and what to monitor for that. I mentioned with the milrinone, you want to be careful with renal impairment, so know that. Know the clinical effects on hemodynamics. I think that's super important. So we had a question earlier, like what do we monitor in these patients? Well, we're going to monitor weight daily. A lot of these ICU beds have a built-in scale, so it's easy to monitor the patient's weight. But if not, if they're ambulatory, you can, of course, monitor weight. Certainly, we're going to monitor intake and output, fluid intake and output. So what's going into the patient, and more importantly, what's going out. Your goal, again, is a net negative of 1 to 2 liters per day, ideally, in these patients. You're going to monitor clinical signs and symptoms of patients with who are wet or patients who are cold. So wet would be edema, ascites, rales, JVD, orthopnea, dyspnea, fatigue, etc. Vital signs in EKG, you're going to monitor several times a day. That's including blood pressure, heart rate, EKG probably daily in those agents that are proarrhythmic. Electrolytes are going to be done daily, especially sodium and potassium. And then renal function, you're going to monitor periodically, at least once a day, if not more. If the patient has inadequate organ perfusion or inadequate cardiac output, you're going to be monitoring it more frequently than daily. Chronic medication considerations. So what do you do when the patient comes in with acute decompensated heart failure on a whole list of chronic medications? So this is a nice summary of what to do. With the ACE inhibitor, ARBs or ARNIs, if you have worsening kidney function or significant hypotension or hyperkalemia, you're going to hold that therapy. For beta blockers, if they have low cardiac output, hold. If they're in cardiogenic shock, hold the beta blocker. Certainly if they're bradycardic, you're going to hold the beta blocker, or significant volume overload. So basically you're going to hold beta blockers in most of these patients. Aldosterone antagonists, if they have hyperkalemia or renal dysfunction, you're going to hold aldosterone antagonists. And then the SGLT2 inhibitors, you're just generally going to hold it during acute therapy. Importantly, you may resume the guideline-directed medical therapy once a patient is euvolemic, meaning their volume on board is normal and everything is stabilized, especially their hemodynamically endpoints are stable. So once those are done, and you stabilize a patient, you diurese the patient to euvolemic status, you can gradually resume their home meds. What can pharmacists provide in these heart failure patients? A lot of things. It's a busy slide, but we can certainly provide pharmacologic optimization, right? We're the experts in that. So we can surely help out with diuretic therapy, inotropic therapy, and vasodilators as far as which ones to use, how to monitor, and how to titrate on or off all these. So adjusting the medications. We're going to monitor for adverse drug effects and for safety. We can do medication reconciliation. That's important because you want to make sure that you have a clear understanding of what the patient is taking at home so that when you discharge them, you can further optimize their medical therapy so they don't get readmitted. Excuse me. Educate the patient along the way, especially at discharge from the hospital, and then a whole host of post-discharge and outpatient roles that you probably went over in chronic heart failure. Summary, remember that there's a lot of precipitating factors. So ideally, you want to identify and control or correct the precipitating factors as you can, as best you can. These patients will come in fluid overloaded, so their volume status will generally be wet. Their perfusion may be warm or cold, so you need to be able to identify whether the patient is in warm or cold and wet. Loop diuretics are the backbone to managing congestion, so you're going to start those almost immediately in most patients unless they're hemodynamically unstable. Vasodilator therapies will assist with symptom management in patients who aren't improving with diuretic therapy. Inotropic agents are considered in severe cases who don't or who present with organ dysfunction or low cardiac output. And don't forget about sodium restriction. Questions?
So non-pharmacological care would just be sodium restriction and oxygen.
So non-pharmacological care, certainly oxygenation. You want to make sure they have adequate oxygen. Oxygen is important. Sodium restriction, fluid restriction once they get stabilized. And avoid anything that's going to cause sodium retention like NSAIDs and things like that, right?
Thank you.
Thank you.
Thanks for staying, folks.
Thank you.
Have a great day.
All right, let me turn off Panopto here real quick. You familiar with that?
I've used it once.
Okay, let's.